If you've ever been to a conference talk where the slides suddenly turn into graphs and statistics that you don't understand, and you're not totally sure what you're looking at, you're not alone. The good news is that you don't need to understand every mathematical equation for every statistic to understand whether a study should influence your practice. In this short series of videos, I want to show you how to quickly get your bearings when you're reading psychiatric research without getting too lost in the numbers. Every good study starts with a clear question. Just like it helps to know your destination before you start driving, it helps to know what the study is actually trying to answer before you look at the results. A strong study decides its question before collecting the data. That's called an a priori hypothesis. That question should be clearly stated, usually before they describe how they set out to answer those questions. This is the hypothesis, and it usually shows up just before the methods section in a paper. Now, sometimes researchers will take data from a previous study and reanalyze it to look for interesting patterns. That's something called a post hoc or subgroup or a secondary analysis. It's kind of like realizing you took the wrong turn, and instead of eating dinner at the restaurant where you planned, you decide you're going to make the best of it and try and find somewhere else to eat. And sometimes, you'll be pleasantly surprised. Now, post hoc findings aren't useless, but they are prone to biases, including cherry-picking data that supports a hypothesis. And this is because the original study wasn't designed to answer that post hoc question. These kind of studies will tell us what might be worth looking at in the future, but shouldn't be considered definitive and probably shouldn't immediately change your practice. So all else being equal, you can put more confidence into an a priori study that clearly asks its question up front before it began to collect and analyze the data. The real question from any study is simple. Can this help my patients? And this starts with asking who is included in the study and who is excluded. Many psychiatric studies exclude people, for example, with substance use disorders, medical comorbidities, or complex presentations, like having more than one diagnosis or having a personality disorder. That can make results cleaner, but less generalizable. There's always this trade-off between tightly controlled studies and real-world patients. The more a study population looks like the patients you treat, the more useful it is for clinical decision-making. But the more it looks like an actual population of clinical patients, the more variables are in play, the more noisy the results will be, and sometimes it makes it more difficult to know if the intervention in the study was what really made the difference. Now, we're human. We learn through stories. We hear things like, I have a patient just like that, and lithium worked beautifully. And those stories are valuable. But stories are actually the bottom of this pyramid. They're the weakest form of medical evidence. Now, expert opinion from eminent teachers can guide us, but it shouldn't be where we stop. Evidence builds upward from case reports all the way up to randomized controlled trials, or what are known as RCTs. And if there's enough RCTs, we can do systematic reviews and meta-analyses. The strongest trials are randomized and blinded, meaning that neither the patient or the researcher or the statistician knows who's getting what treatment until the study ends. Stories, of course, engage us, but it should be evidence that changes our practice. It's also worth noting how drugs get approved in the U.S. It takes many years for this to happen, from phase 1, which is the first studies on humans to understand pharmacokinetics and basic dosing, to phase 2, where we begin to test one of these clinical hypotheses, usually with a small number of subjects. We also begin to collect safety data. And then finally, in order for a drug to be approved by the FDA, it has to have 2 positive phase 3 results, where we confirm those hypotheses that were tested in phase 2, and we continue to find safety data. The FDA requires 2 of these positive studies in order for a drug to be approved. And these studies have to be drug versus placebo, not drug against an existing drug, which is known as a head-to-head trial. So that makes it difficult often to claim that drug A is better than drug B, because often there are no studies that actually compare the 2 against each other.